Thank you.
Ma'am, please start. Thank you.
Hello. Uh,
Ma'am, you can start. Thank you.
Good evening. My case presentation is about Priyansh, a 5 years old male child, second by birth order and born out of non-consanguineous marriage. He is a right-handed child. He was brought by mother, who is the informant, and informant reliability is good, with complaints of fever for 5 days, complaints of pain in the left lower limb for 2 days, and complaints of inability to walk for 1 day. History of presenting illness. On 17th July, child had one episode of paroxysmal event around 2 p.m., which occurred in awake state in form of sudden pause in the activity while standing, with child maintaining his posture, and as it was associated with deviation of head and eyeballs towards left side, and not responding to verbal and tactile stimuli, which lasted for around 5 minutes. The mother uh, tried to sprinkle water on his face, for which the child had intermittent blinking of eyes. And then the child was made to sit by the mother, post which child started swaying towards the left side, and he had tightening of left upper limb and left lower limb, which was associated with drooling of saliva from the mouth. And all these events lasted for around 15 minutes. It was also associated with involuntary passage of urine, and there was antecedent history of fever for 3 days, which was intermittent, low grade fever spikes, not associated with rash, chills, and rigors. It was relieving with medications, and child was active in the interfebrile period. There is also alleged history of fall from stairs on 6th of July, around 60 centimeter height, and incurred injury on left side of forehead. It was not associated with vomiting. There is no history of vomiting, loss of consciousness, headache, seizure post fall, and no medical attention was sought that time. So, with this paroxysmal event, child was brought in active convulsing state to the casualty, and it was aborted with some medications which was given intravenously. There was no history of double vision, lightheadedness, photophobia, persistent vomiting, or recent travel prior to this episode. And child was admitted between 19th of July and 21st of July for this compliance. Neuroimaging was done. CT brain was told to be normal. EEG was done, for which the report was awaited. And there was no episode of convulsion for similar, no episode of similar events, and fever also subsided. So the child was discharged on anti-epileptic medications on 21st of July. Post-discharge, child was apparently normal for 1 day at home, and on 22nd July, again he started having fever, which was documented 120 degree Fahrenheit.
लेक्चर बाहर जाओ बाहर जाओ बाहर जाओ का ये तो आवाज कमी कर रहा था
Sir, we cannot hear you. Sir, you are muted.
Nivedita. Now you can
Yes, sir.
hear?
Yes, sir. Yes, sir. Now you are audible. Yes. Thank you.
No history of recent vaccination or no history of COX or COX contact. Past history. Parents notice child having intorsion of left leg around 3 years of age and which is seen prominent while standing or walking. An X-ray local done. Child was advised to take calcium and vitamin D3 supplementation. Next is antenatal history. History of one stillbirth present before this child. Then this child is spontaneously conceived. Antenatal scans were done 4 times. All were told to be normal. Iron, folic acid, and calcium supplementations were taken. Fetal movements pursued normally. And antenatal history is non-contributory to the current compliance. Birth history is a full-term baby born by normal vaginal delivery with birth weight of 2.5 kgs. He cried immediately after birth. No history suggestive of neonatal encephalopathy, and child has attained all the age-appropriate milestones prior to the illness. Diet history. His actual calorie intake is around 2,250 with a deficit of 150 kilocalories, and actual protein intake is 21 grams with no protein deficit. Child is immunized till date according to national immunization schedule, and socioeconomic history belongs to lower socioeconomic class according to modified Kupusamy scale. Clinical summary.
So this is the first event that child had a paroxysmal event, sudden pause of activity while standing, all this description. So what is your thought on that?
Yes, sir. हाँ सर 3 days fever and उसके बाद he had a
So really, then you should have put that first. It's very confusing. So this fever, can you tell us, you told us the details of this fever? Huh? Repeat it.
the child had a fever for 3 days which was low grade and it was not associated with any chills, rash or rigors, and it was relieving with medications with the child being active in the interfebrile period. There is no history of decreased appetite or decreased activity. Then on the 3rd day of illness, child had this paroxysmal event.
Third
Third
day
day,
of the
third
fever.
fever.
Third day or 3 days and then fourth day?
3rd day of fever.
Third day of fever. But fever was low grade. Documented or not documented?
Not documented, sir. On arrival on presentation, the child had fever. During first admission, the fever got relieved. Then after that post,
No, one sec. So the child was brought in a seizure, right? You said.
Hmm.
Then in 2 days he recovered and he was discharged. So when did the fever disappear? On arrival, he had fever. Next day, fever disappeared.
Hmm.
When we start with 16th with fever for 3 days, and on 19th, the last day of fever, there was an episode. Thereafter, there was no fever and no episode thereafter.
One day beyond seizure. So seizure was one event in the fever.
No great fever.
Yeah.
Okay, so fever for 4 days on day 3 event. Okay, that's fine. All right. So you could have started with fever. Okay, we get an impression that it was a sudden episode that occurred. That was not the onset of problem. Onset of problem was with fever.
And again, you have started with, means in your presenting complaint, you have again said something which happened after all this. So it's all very confusing. There are uh, three periods of illnesses. So you should have started with saying that this time this child has come with these complaints, but he was not apparently all right prior to this. So I will start from the beginning. And then you would have said 16th fever, 19th seizure, then 21 went home, then 23 again, all that, right? It should always come as a story. So anyway, so now 3 days of low grade fever followed by this seizure. So two things. One is overall impression. What is your analysis? And second is anything different that you notice in this seizure?
There was no loss of tone. Absence is very low.
It was an absence seizure. Hmm?
Focal seizures followed by generalized seizure.
What is described as that he was pause in activity while standing, maintaining his posture with deviation of head and eyeballs to left side, not responding to verbal and tactile stimuli. So I'm trying to understand this phase. You're calling this a absence seizure?
Might be aura.
Might be an aura. So during an aura, the patient doesn't respond. So uh, what is the difference between a partial and a, or rather a focal and a generalized seizure?
Sensorium is intact in focal seizure, and generalized sensorium is affected. Child is not aware. Usually, focal seizures are preceded by aura.
So aura itself denotes focality. Okay. So this statement that focal seizures are preceded by aura is not right. You have different types of focal seizures. So focal motor seizure will not be preceded by an aura. But an aura itself is a sign of focality. You have focal seizures with impaired awareness. So that sensorium point as a differentiation between focal and generalized is also tricky because you have focal with impaired awareness. So, I mean, I think that this started as a focal seizure and then became generalized. So that first phase was focal with impaired awareness, but it's a little confusing history. I'm not sure whether he was really standing and whether he could maintain his posture, even though he was not able to respond. It's a little confusing.
I think to me there is no focality in this. Okay. The story looks like, if you look at that, he was standing, okay, and could not maintain his posture. So we'll we'll call it an atonic seizure. He lost the tone. And then that was associated with deviation. While standing, he maintains the posture and not responding. How can that be? How can he stand and still not respond? No, no. If you are sure about not responding, then rest is not dependable. This is a generalized seizure. Okay. Karan, how can you stand and still not respond? Isn't it? So those, I think, things are really not very, very clear about it. And I think this is how history taking is a very, very important time consuming skill. And we always say history is not his story. This is exactly what it is. This doesn't lead us to anywhere else. If we are not sure what was the fever like, at what age, time of fever the seizure came, what kind of seizure it is, then we are losing the whole grip on the whole story. Okay.
Sir, I thought this is possible, that he can lose sensorium or consciousness, but he will not lose posture. It can happen, this partial seizure, he looked like that, he did like that. He was not aware, but he was sitting all that. I think it is possible. So it has started focally, but it has not remained focal. It has affected his sense. It may not be generalized loss of consciousness and loss of posture both. But with focality, with altered sensorium, I thought there may not be loss of consciousness. And most of the focal seizures will occur like that. ऐसा किया, फिर थोड़ा सा confused था, फिर ठीक हो गया.
But not responding.
So he was altered sensorium, but did not lose posture. We will confirm this. Sir.
If you are I feel that is not possible.
Sir, for example, in petit mal absence, there are loss of consciousness, but there is no loss of.
Standing, you lose consciousness and continue standing.
Yeah, means in absence.
Absence is
No.
not loss of. Absence is for a transient loss of reality. When I'm writing on the board, I suddenly stop for 2 seconds and continue writing.
Yeah, but that absence is not recorded by but in that short time is not conscious. He has loss of memory also for that short. He doesn't remember that particular short period is non-existent for that patient.
I'm not sure whether absence can be said to be
Absence is,
with a loss of consciousness. Absence is a transient disruption of what you are doing. Transient disruption.
yes.
Let's see how it is, but I think this is not clear. But in an absence, nobody loses. But that is because he is conscious. But for some reason, there is a disruption of activity which is resumed immediately. This is my thinking about absence.
So anyway, so now this is a little confusing history, but I think as students, you must realize that why did he maintain or remain standing? So that's quite unusual. So you need to ask about that. Now, assuming that he had a generalized seizure after 3 days of low grade fever, what is your thought process on that? So start from means anatomy is obviously cerebral cortex. He has a generalized seizure. So now what do you think is happening?
Remote symptomatic epilepsy towards it might be.
We will divide if it is symptomatic or acute symptomatic or remote symptomatic. Since the child is developmentally normal,
सांगितलं ना भेटले ना मॅडमला तुम्ही कुठं तुम्हाला ह्याला जायचंय वेदांतला जायचंय हा
Sir, since fever was low grade and we don't know if child has vomiting or altered sensorium, can be meningitis, but unlikely.
Why we don't know? Ask no whether there's vomiting, whether there's altered sensorium. Hmm?
There was no history of vomiting or altered sensorium or any neck pain or nothing like that. So only fever.
Correct. So now what do you think? You think this is meningitis? So why is it less likely to be meningitis? Give us your points.
No history of lethargy, decreased oral intake.
What is the difference between meningitis and encephalitis? And let's see whether the symptoms are of meningitis or encephalitis. Is there any difference between the two or they are same?
Encephalitis, there will be associated altered sensorium will be there. And
Encephalitis cortical involvement is there. Meningitis, no cortical involvement.
What are the symptoms of meningitis?
Lethargy, irritability, decreased oral intake, fever, high grade fever.
These are not symptoms of meningitis. No, these are just general common.
I think the early symptom of meningitis is just fever, and maybe on examination you might find some stiffness. As the disease comes up further, there is a raised ICT, and the first symptom of it is irritability and vomiting. Okay. If you ignore it, then these symptoms get worse, but still the person is conscious. But thereafter, younger the child, he starts developing an encephalon involvement. Older the child holds on with meningitis for a long time. So this cannot be meningitis at all. In fact, there is no meningitis here. There could be encephalitis, that is fine.
To give you an example, in mums often there may be meningitis. In fact, they can have, it's said that many cases of mums may have meningitis if you do the CSF. They may have only irritability, vomiting, and maybe some raised pressure. There is meningeal involvement. It does not tell you anything about the involvement of other part of the body. There may be associated encephalopathy also. There may not. I gave you one example where there is no associated. So these two things are different. So irritability, vomiting, raised intracranial pressure is meningitis. And the signs may be subtle, may be subtle.
And it's not that the cause of meningitis, whatever the organism, is spreading to encephalon. So encephalon is involved by non-infective mechanisms. As the raised ICT comes in, the circulatory problems start coming up. Not all areas are well perfused. That starts an encephalopathy. In tuberculosis, if it's an immune mediated to the tuberculin, and therefore it's again an immune mediated encephalopathy. So meningitis doesn't extend as infection to encephalon, but a complication to encephalon. And I think this is encephalopathy, not even necessarily encephalitis. For saying itis, you must have fever. Yeah, there's some low-grade fever, but that may not be enough. So we'll call it encephalopathy at this age.
So what could be the possible cause of this encephalopathy? Since we are saying it is not encephalitis, so infective is less likely.
Sir, any low-grade infection like tuberculosis or autoimmune or tuberculoma.
Correct. So now examine all your own statements and think. So low grade infection like tuberculosis. So to find that out or to suspect that, what do we need to do? Before 16th, when this fever started, how was the child? Was he normal, abnormal, well nourished, all that? So all that answer
He was normal and well-nourished child, sir.
is absolutely normal. So that first part. Then you said tuberculoma. So usually tuberculoma presents as what? They present with fever, focal seizure. Here we are talking of generalized seizure. Okay, and they don't present with first low grade fever for 3 days, right? So tuberculosis or tuberculoma does not come in the forefront here. Huh?
SOL.
Again, SOL will come with either a focal seizure or a focal neurological deficit, not a seizure like this. And also note that this was a kind of a status epilepticus. You've said such a long first 5 minutes, all that. Then the child was made to sit, then drooling of saliva for 15 minutes. And then you said that the child came here seizing. So that means the seizure duration has been pretty long if all this is correct, which is by definition status epilepticus. Now, upfront, suddenly out of nowhere, why status epilepticus? So many things are little, difficult to explain. But doesn't look like SOL or any of those.
So either this fever has something to do with the seizure or it may have nothing to do with it. It was too short lasting. I would have been happier, though not essential, if there was an intervening normal period. That gives us an opportunity to explain there was illness. There's a pause during which the antibodies developed and it produced an autoimmune. So there was no such thing. It was merging. So I don't know whether it was part. If it's part of the illness, look too trivial. So unless
But
the
still, maybe
because
immune
the
mediated seems more
more
likely
likely.
than anything else,
And you
like a
have those
infection.
neurotropic viruses, etc. We don't know all of them. And how do they prodroma begin and how soon they affect your nervous system. But maybe since the things were low grade, immunological parameter, but immunology also often gives rise to very high fever. We'll keep that open. We'll be little wiser as the time goes.
Sir, the recovery also goes against a neurotropic virus. I mean, he recovered within a day and he was fine. So this is not a neurotropic virus. Now, do you think this fall is related, not related? How will you argue for or against? So what are the different things which decide whether you have a significant head injury or no? Hmm?
After fall, if the child has loss of consciousness, vomiting, bleeding from ear or nose, or convulsion, this all signifies that there is some injury that has happened, significant injury that has happened. Nothing is present here.
I mean, that is very obvious. If you fell down and you have bled and all. Our question comes when the child had a fall and he was all right and he has been brought to you after an hour, hour and a half. He may be relatively normal. They are asking you, do you do a CT scan or you don't do the CT scan? Number one is exact history of fall is also important. He fell down from an 18 inches height and then is different. And he fell down while climbing the ladder. So nature of fall, how did he fall, etc. But in one of the neurology books, they have written loss of consciousness, however short it may be, is an indication for a CT scan. So we'll keep that in mind.
Right at the fall, if there is a significant hematoma, okay, maybe some blood coming from the nose, which tells you the severity of the impact. So that, but which is not common. They look all right for about 8, 10, 12 hours, and thereafter the problem comes. And therefore, if they are fine immediately, it does not rule out the complications at all. And in the next 12, 14 hours, most of them vomit, but have nothing neurological. That vomit is of no concern. That vomit is out of fear of what has happened and thereafter. So vomiting is not an indication of CT scan, but a neurological symptom or signs are. And therefore, this is absolutely inconsequential. And this is 60 centimeters, so hardly a fall worth discussing, right?
Okay, so then you said this child was admitted, nothing happened after that, everything was fine. And so this child was discharged. And after 1 day, discharge 1 day normal, and then again had fever, which was documented 101, and then started complaining of pain in the left lower limb, right? So now what do you make out of this?
Would you have discharged this child
After the first thing.
when he was admitted? First time he had that and confusion and all that. That was the first time. He was admitted, and after some time, you must have given him anti-epileptic therapy and he recovered. Would you have discharged?
Sir, they did imaging. No, imaging is normal. So what else now? His child was also fine. So what to do?
But the history was not very fine.
What is the first investigation in a child at this age with seizure? Is it CT scan? No, it's a CSF. After all, CSF is the first investigation for a seizure, not EEG, not CT. So CT is useless at that time. See, every seizure, especially with fever, has to have a CSF. Okay, and he's an older child.
5
It's
years.
not a simple febrile seizure. So CSF should have been done. And even if it was normal, one would have waited on to say, let's observe for a few days. Maybe you have nothing happening, then we will send you home. Because this is a very highly suspicious story and likely to progress into trouble. So I think that would have been the right.
We were not very clear about the whole story, so we would have waited.
She made the child to sit from standing. He was standing only and he was very unresponsive
I
to any
agree with you.
stimuli.
He was standing, so there was no loss of posture,
Huh.
but there was altered sensoria for quite some time, which was not very easily explainable. Now, that's something which will, and he had a generalized seizure for nothing and he recovered. Then you may call as this may be the first evidence of a epilepsy that the child is going. That was also not so. The history is not so clear cut that I will diagnose this as maybe the first seizure of the seizures to follow part of epilepsy and send him.
So what is this pain now? He has got fever again and now he has got pain in the lower limb. So what is this?
It's not myalgia. Myalgia will be generalized, but he's specifically saying only pain in the left lower limb.
Which means the pain is what? Vascular myalgia, you are saying it's not there. Then what is the pain?
Might be vascular.
Why vascular pain in one leg and after 1 day of fever?
Pain, neurological related.
It seems more like a neurogenic pain, but the problem is again that neurogenic pain means it is like a root pain. And a root pain is a LMN symptom, and that's a little difficult to explain here considering the past story. Means, like we were saying, if that was immunological and this is the second phase of the illness, it's likely to be spinal cord involvement where pain is a little difficult.
The roots are involved. So the roots are involved. There's definitely a neurogenic pain. Vascular would have been just localized. This is neurogenic, and possibly you are looking at an involvement of the roots in this. And therefore, to begin with, now we said encephalopathy. This doesn't look like an infective encephalopathy. Then what encephalopathy it is? It's either immune mediated or a metabolic. There's no reason for metabolic disturbances with such a story. Therefore, it has to be immune mediated. It is acute, so we'll call it acute immune mediated. It is disseminated. Yes, now it's getting even disseminated from encephalon to myelin, myelopathy. So add a word, ADEM. Okay. What would have been the ideal situation is what Dr. Khare said. 3 days of fever, 1 day normal, 1 day, 2 day normal, and then autoimmune phenomenon. But all this requires a very detailed history. Okay. If you say that fever was still on when a first seizure came, that's not the way ADEM typically present. ADEM has a small 1 or 2 days gap between normality and then sudden seizure. But all these are details. So learn to ask every detail. Parents may not know. That is fine. Parents may not be reliably able to answer you, but your question should be put up there in that, right?
So there was a question whether this is a sensory seizure or an aura. So actually aura has to be time bound, as in it has to be for a short time or something. This was pain was constant and then it was followed by a weakness. So this is definitely a neurogenic pain. Only thing is I was getting a little confused between the localization of roots being involved, that was also sure, but whether in a spinal cord myelitis, whether we can get roots also, so that was my confusion. But yeah, that's what must have happened. So this is now spinal cord roots getting involved. Okay. Then the difficulty in walking progressed and he had both lower limb weakness, right? Yeah, so all that is fine.
There was some anterior something of the knee. What really do you mean?
Mother must have described that, but
So what
basically
exactly
it's just a
happened?
weakness.
The child initially had lost walking without support. He can walk with support, but he had forward bending of the body and bending of his
Yeah,
knees.
it's, something like buckling of the knee. If you have a weakness here, suddenly your one knee goes down. If you have power, you will say that. That tells you that this neurological weakness concerned with extension of the knee joint.
Now, see how here now you say no history of seizure. Now, your whole story started with that big seizure, and then if you say no history of seizure, it doesn't present well to the examiner, right? So, we have to be choosy about our words and we have to be showing that we have presence of mind. So, now this no history of seizure, what did you mean? What did you want to say?
In this current admission, there is no re-episode of seizure.
So you should have used that word, that there is no history of any additional seizure besides the one which we originally presented with. Just saying no history of seizure means it's confusing. It means that you have ignored that previous seizure, right? Similarly, altered sensorium, and then okay, no other localization you are saying. Okay.
What is that inward torsion? What is that?
Internal rotation of lower leg. Like he will walk like this one day with inward.
What is it known as? Intoeing. It may be normal, means it is common, may not be a defect, neurological defect, but many children walk like that. And a typical thing that the parents bring the child is for what? This boy or girl has W sitting. They cannot sit cross-legged because their internal arrangement at the acetabular joint is such that the angle between the femoral shaft and the acetabulum is such that they cannot keep it like that. Angle, unless the angle widens, the leg will not remain straight. So they have to sleep like. On the other hand, those who have out-toeing, they cannot, they find difficulty in having W sitting. Over a period of time, it may get corrected, or sometimes they may have all, I mean, even in an adult, some people have into. The books mention that the treatment lies in making them cross-legged sit. So if you make them sit cross-legged over a period of years, then it tends to get correct.
Incidentally, while presenting history, you should not use the word intorsion. So you should talk in parent's language that he keeps his foot pointing inwards. Okay. Come now, give us your.
Clinical summary. A 5 years old male child brought with complaints of fever for 5 days, with pain in the left lower limb for 3 days, followed by difficulty in walking with staggering gait, very possible cerebellar involvement with intact sensorium, and with behavioral disturbances, with antecedent history of one admission for fever with left focal status epilepticus of unknown etiology. Also, there is history of alleged history of trauma 13 days back in a birth and developmentally a normal child and age who is age appropriately immunized. Is maybe is a probably a case of acute meningoencephalitis with cerebellar involvement to rule out infective etiology, either viral or tubercular or autoimmune encephalitis.
I didn't understand the meaning of difficulty in walking is staggering gait. Means
Without,
what was that? He was walking like a drunk pad, or he was dragging his leg?
initially, he can walk while when walking with support. He like he can walk with support without any gait disturbance. But with when the support is released, he was staggering. He's losing his balance.
So that is not cerebellar. See, when you are weak, you need support. And when you don't have support, then you will lose balance. So that may not be cerebellar, that may be just weakness.
Logical weakness. Yeah. And he already had something like giving up the movement of the knee.
This is the child before presentation. Current. This is on the child actually presented on 25th July. This is one day before the illness. Like he was holding something and okay.
Why was this video taken one day before the illness?
Actually the parents they noticed something is wrong with the child. Then this video also like he complained of pain and then the child had some gait they that's why they shooted this video.
Okay.
Could be swaying here when he was walking. Just
And this is after that, some time after that video.
but lower limbs also pose some problem, not very. normal. Okay.
This is during presentations on 25.
Did he sway on standing or only on walking?
Only on walking. He is not swaying on standing. He didn't sway on standing. And he was so afraid of even lifting his leg. On examination, child was afebrile on presentation with heart rate of 118 per minute, RR of 26 per minute, saturation 99% in right upper limb, peripheral pulses were well felt, extremities were warm, and BP was 90 by 54, which is between 50th to 90th centile, and blood sugar levels were 102 milligram per deciliter. Then head-to-toe examination, no significant abnormalities present. On the attitude of left lower limb on standing, there was inward internal rotation of left lower limb present, and forward bending of bilateral knees while walking noted. There are no neurocutaneous markers. This is a child. It's a left limb actually in towing is present. Anthropometrically, child is weight is 14.3 kgs between -2 to -1 standard deviation. Height 102 centimeter between -2 to -1 standard deviation. Head circumference between -2 to -1 and mid upper arm circumference between -1 and 0 standard deviation. Weight for height is between -2 and -1 standard deviation. Impression child is normal and appropriate for age. CNS examination, higher mental functions were normal. Child, child's child is a right-handed person, and gait, child had staggering gait when attempted to walk without support. In cranial nerve examination, no significant abnormalities present. Both direct and indirect light reflexes were there. In motor examination, tone was normal in all the four limbs. Power, in left upper limb it was 4 by 5 and left lower limb it was 3 by 5. Then left hip tenderness was present, and reflexes superficial, all the superficial reflexes were present, and all the deep tendon reflexes were brisk in all the four limbs. The plantars were extensor on presentation, and ill sustained ankle clonus was there.
Plantar extensor on both the sides.
Huh. And meningeal signs, neck rigidity was present. Other rest of the system examinations were normal. Yeah.
One sec. Go back to your findings. So now what do you make out of these findings? First analyze that.
Left side of the body, child is having lower limb involvement more than the upper limb.
Right side is apparently normal, no power. So that means this is a hemiparesis. Is it a left hemiparesis?
Yes.
You all agree this is left hemiparesis? What? In hemiparesis, which limb is more affected, upper or lower? Here? So what I'm trying to say is I would rather check all that. If it was really hemiparesis, I would not get bilateral brisk jerks. Bilateral brisk jerks, when do you get? In any CNS situation? Raised ICP. Does he look like raised ICP in any other way? So if he has bilateral brisk jerks and he has left upper limb which is better than left lower limb, then I'm little skeptical of calling it hemiparesis. That is one point. Second point is How did you make out hip tenderness? Means what did you do to make out that left hip is tender?
Single leg rising test.
Single leg
Rising test.
means exactly what did we do, and
We will make the child. We will make the child lie down, and we will ask the. We will lift the child's leg in with without bending his knees, and
means straight leg raising test you are saying. So straight leg raising test is not a sign of hip tenderness. What is straight leg raising test a sign of? Root
pain.
pains, no? So root involvement. Okay. Why I'm pointing this out is it is very difficult to make out hip tenderness clinically, and it is relevant in practice when you get a child suddenly who's limping and you find that your passive movements on one side are less and you suspect transient synovitis of the hip. I mean, your passive movements are restricted because of pain, he gets into a spasm. Otherwise, it's not easy to make out hip tenderness. So what you are describing is SLR positive, which means root pains. Okay. And ankle clonus is again on both sides.
Both the legs.
Yeah. Ill sustained, she has written. Ill sustained. Okay, go on. Okay. Yeah, so she's saying neck rigidity. Now, whenever you have neck rigidity, you match it or you kind of look for which other signs? Neck and leg sign. So what are those signs?
Kernick sign and Brudzinski sign.
Yeah, what are those? Means what did you look for?
In Kernick sign, on flexion of neck, there will be flexion of the
Hip.
hip.
Did it happen in this child? No.
No.
And when you, what is the other sign? Leg sign?
This sign, when we flex the hip, then the other hip will also automatically.
Correct. So did it happen? So again, it's a little suspicious. Means you need to check on all this, right? Okay.
There are two issues. One, you did not expect a meningeal sign. That's number one. Now, if you look at it, there is a small difference between a neck muscle spasm and meningeal sign. And the way to differentiate is you bring out the head and neck of the baby outside the bed. So if this is a baby lying like this, I bring him out like this and let the head hang here and then see whether I can easily move it. That would indicate that it's not a meningeal irritation, but just a spasm. The reason I'm saying is that your history said that there has been some pain in hip, neck, and spine, something like that. So is it some multiple areas of root pains involved? After all, what we are looking at this patient is a disseminated lesion. Disseminated. And therefore, even bilateral plantar could be a disseminated encephalopathy. Okay. And here is again multiple areas of roots involved, including the cervical, because that correlated with the history of pain in the neck, hip, and the spine. So I think it could be that meningeal sign. Lastly, in children, many times we say that a 3 plus power is near normal. Now here, 4 plus in the upper limb, which is quite normal. 3 plus, pain is the cause. So you are putting one less. So again, it's not a weakness really, it's a pain, right?
And many times coming to your modified sign of meningitis, sometimes children keep it stiff. And you don't know whether this is voluntary stiffness or no. So you bring his head away. He will not do any voluntary stiffness when the head is away, because otherwise the head will come down. and then also the meningeal signs persist, then it is genuine meningeal sign.
So there is a comment from online that the sensorium is good if we are suspecting ADEM. So I think the issue is that ADEM can be dissociated in time. So the E and the M get dissociated in time, and that is the problem. So what he had the first time was the E part, and now he is having the M part. That is possible.
Child also had behavioral disturbances post admission. This one, second admission. Like he was biting the parents and beating them, and he was very irritable.
And I think the word D is a disseminated lesion. So we are not talking about an acute encephalitis where the entire encephalon and cortex is involved, that you have a sensorium loss. Otherwise, in a disseminated cortical lesion, there is no reason to loss. You know that you need a bilateral cortical lesion to be affecting the sensorium. This very word is disseminated, and therefore it's not uniformly affecting bilateral cortex, and therefore ADEM is fairly conscious. Okay, ADEM need not be unconscious at all, but an acute viral encephalitis is unconscious because it's uniformly affecting the cerebral cortex.
And she's also saying, I mean, I had missed it, but she's saying there are behavior abnormalities post this episode. So, all the more reason that there is some encephalon involvement even now. Go on.
A 5 years old male child who was brought with complaints of fever for 5 days, with a pain in the left lower limb for 3 days, followed by difficulty in walking, and with intact sensorium initially, followed by post-admission child started having behavioral disturbances, and also with antecedent history of one admission for fever with left focus status epilepticus of unknown etiology, with alleged history of trauma 13 days back, in a birth and developmentally appropriate and age appropriately immunized child who on examination has signs of meningeal irritation, is probably a case of acute meningoencephalitis to rule out infective etiology, second autoimmune encephalitis. Investigations, CBC total counts were 16,000 with the neutrophil predominance, neutrophil 67% and lymphocyte 25%, hemoglobin 11.6 with a hematocrit of 31, and platelets were 383,000. LFTs are total bilirubin 0.4 with AST and ALT 16 and 25, BUN create 6 and 0.8. Serum calcium levels are 8.7 on presentation. Next, CSF was done. CSF showed a total counts 150 cells with the lymphocyte 80% and neutrophil 20%. Protein was 18 milligram per deciliter. Sugar levels were 45 with corresponding sugar of 100 milligram per deciliter.
Okay, wait. So, do that last line, kindly correlate clinically. Correlate, chalo. What do you think? Meningitis or no meningitis?
Meningitis, 150 cells.
Can be viral. It can be viral meningitis, but or autoimmune.
I think if you go theoretically, cells are abnormal. Okay. And that's why even the person who has done it, otherwise it's rare for a CSF examination report to say clinically correlate. X-rays, radiologists keep on saying that. Or if you're doing a malarial parasite, they might say absence of parasite is still not necessarily ruling out malaria. But this statement itself means that the person who has read this slide is telling, don't go by 150 number P820, etc., it may not be right. So I think we will have to really look at all this. And this is certainly not expected. If I'm giving only this, I will cause it a meningeal irritation, meningeal inflammation, but we don't expect it there. And I think he has, instead of writing, don't depend on my cell number, he has written it correlate clinically, right?
There were no RBCs. By chance, it was traumatic. But sometimes it can so happen. The sugar is normal. Only the cells are raised. Proteins are. So sometimes I think some of diseases, initially the sugar is raised, then it comes down, then the proteins raised and they fall down. Some of the meningitis, this one. Initially there is rise of sugar and then proteins come up. I don't remember exactly what disease. This will be known only after a follow-up. But I think it is meningitis with 150 cells, which is difficult to explain on what we had thought.
Commonest cause is a mild trauma. RBCs are not reported, I understand that. But possibly that may be the only reason if he has done it correctly. And to that extent, we'll not worry about that CSF. But I'm happy you did a CSF. Okay, because if you have to say meningitis, you have to do a CSF.
So means I think let's use the word meningeal irritation because as you rightly said, proteins are also bang normal. And in fact, that's a problem because in immunological diseases, proteins also go high. That's your cytoalbuminous dissociation.
But in a very early bacterial meningitis, very early, 5 polymorphs is the diagnosis of bacterial meningitis. Proteins are yet to go up, sugar is yet to go down. But this is just to remember that cells are important, but all the same, this is clearly not real.
That will be also in a younger age.
MRI was done. MRI was initially CT was done. Again, repeat CT showed no significant abnormality. Then MRI was done. MRI showed few ill-defined non-enhancing T2 flare hyperintense foci, not showing restricted diffusion or blooming on GRE in juxtacortical and subcortical white matter of right high frontal lobe. Linear flare hyperintensity is not showing restricted diffusion or blooming on GRE or noted in the bilateral frontoparietal lobes. And MRI C-spine showed long and short segment, non-enhancing T2 stir hyperintense and T1 isointense signal intensity in cervical and dorsal spinal cord as described above. All these above features were suggesting of demyelination, probably Mogad or Adam. Then EEG was also
Initial clinical diagnosis stays. In the beginning, it was thought that it was ADEM, and even after everything, the final diagnosis remains ADEM. And your initial story itself was very peculiar, that altered sensorium and difficulty, but so that showed that there was something happening higher up, and then frontal lobe is involved here, suggesting so diffuse areas of brain are also involved, and of course, spinal.
I think when we say normally now in our presentation that history given by the mother reliable, how do you make it reliable? Okay, Balasubramaniam says every mother is reliable. So then you say only mother, don't say reliable. Okay. The point is, by saying that the history is reliable, you are trying to tell an examiner that I have to try putting many cross questions to the mother and still the answers come similarly. So I feel it's reliable, which we don't do that. It's a part of a normal respect to the mother that the history is reliable. Okay, but reliability is always a question. We are we are putting up a video in our series, and I'm going to talk about how to ensure reliability.
You can say history is honest. Reliability and honesty are different.
Trump reliable? No.
One other point So honestly, all along, both after your provisional and your final diagnosis, meaning after history and after examination, I was quite surprised why you were talking of meningitis first, meaning your diagnosis was meningitis, then possible etiology viral tubercular. All that was based on the CSF report, right? But what I'm trying to say is in exam, it is not going to be tenable to give a DD of meningitis in such a child. If this child were to come to you in exam, it will be very difficult to defend. Besides the point which we made of sequence, etc., you saw the video. Do you remember any meningitis child who has just difficulty in walking and who's otherwise fine? Do you remember any meningitis child? How are you going to pass it off as meningitis? Right? So think before you give a DD, whatever the investigation show. Your DD should be based on your clinical findings. Right? Okay. Sure, good.
Abnormal.
The abnormal bilateral paretotemporo-occipital interictal epileptiform discharges were present, and MOG antibody panel was done, which was positive, which came positive.
What is the importance if MOG is positive? Come. Does it mean anything? If it doesn't mean anything, why did we do it?
MOG is negative, will it be Amdekar encephalitis?
No. So there are two issues here. One is that there are multiple different antibodies associated with these autoimmune phenomena. So that is one issue. So you want to know which. But there is a importance in terms of prognosis or future prediction. Okay, what is likely to get affected. So MOG is very strongly associated with recurrent ADEM. So there is a prediction that this child might get a ADEM again later. That is the importance of MOG, right?
Edem.
ADEM तर आहेच sir. ADEM, there is no question. It is ADEM. चल, second case. You want to connect that? You all decide what to do.
Is also suggestive of initially started with affect of sensorium, something like seizures, then nothing like that, then motor phenomenon, then pain coming down to so this is where the lesions are jumping from one area to another.
Will take about 4-5 minutes for the second presenter to organize her laptop.
In books, it is mentioned that we should repeat MRI after 3 months or after clinical improvement. Is it practically done?
I don't know that. I don't know the answer to that. But are you treating with steroids? Okay. Yes, Palni, ADEM is different from autoimmune encephalitis. We understand that. But the whole point was that all these immune mediated phenomena, that's what we were discussing, that the etiology is immune mediated and not infection. That was our main thrust. Yeah, so that first fall could have been a temporary seizure or whatever, but that again, we need a very good history to be able to judge that, whether it was really that. But you're right, it could be possible. Yeah, so you're saying no CT except for head injury. So broadly, that is right, but I think the problem practically in all teaching hospitals is that the access to MRI takes time possibly, and because of the lack of surety of clinical analysis or clinical grounds, everybody wants a CT first.
Ease of doing.
But I agree that there should be no repetition, as in why CT and MRI? It should be ideally CT or MRI. You sent it to this laptop or okay.
Hello. Good evening, sir. Sorry for the delay. My patient is a 13-month-old girl, second by birth order, born out of third-degree consanguinity, resident of Dharavi, hailing from UP, Muslim by religion and Sheikh by community, brought by mother with chief complaints of accidental fall from the bed at 12 p.m. one day ago and weakness of the right upper and lower limb noticed thereafter. The child was all right until one day ago when she accidentally fell from the bed, hitting her head while she was asleep at around 12 p.m. in the night. She was asleep from 11 p.m. and had woken up once at 4 a.m. thereafter, was bottle fed by the mother. The child was active and moving all four limbs equally at the time. The child was rushed to the local clinic after the fall uh, at 12 p.m. in the afternoon. And while the parents were trying to console her, the mother noticed weakness of the right lower limb when the child was unable to bear weight on the right and stand. She also noticed weakness of the upper limb when the child was unable to reach out for objects or move her hand. The child was able to roll onto the right side and get up from the supine position by taking support from the left side of the body. On inquiry, the mother also mentioned that she noticed deviation of angle of mouth to the left associated with drooling of saliva from the right. There is also a history of decreased verbal output noticed since morning. There was no history of loss of consciousness, vomiting, or altered sensorium. No history of bleeding from the ear or nose. No history of any involuntary movements or swaying. No history suggestive of any cranial nerve involvement apart from the seventh cranial nerve. No history of any bleeding manifestations. No history of Cox contact. No history of suck rest suck cycle, forehead sweating, or cyanosis. No history of skin rash or any joint swelling. There was no history of decreased oral intake, loose stools, or decreased urine output. No history of stroke in the family. She was initially admitted in the trauma ward and underwent some investigations, including neuroimaging. She was given some intravenous medications and then referred to us. Currently, the child is able to wiggle her toes and move her hand and leg in the plane of the body. Antenatal history was uneventful. Birth history was also uneventful. The child was a full term normal vaginal delivery. She cried immediately after birth, had a birth weight of 3 kgs, and there was no history of any NICU stay. She's immunized till date. Dietary history, she was exclusively breastfed till 8 months, and complementary feeds were initiated thereafter. Developmental history, the child has achieved all age appropriate milestones with a normal developmental quotient in all domains. Socioeconomic history, she belongs to the lower socioeconomic status. Family, she has one elder sibling who is alive and healthy.
So 12 p.m. means 12 in the day or 12 in the night. So you should always say 12 noon. Should not say 12 p.m. Okay? Fine. Come. So what do you all think of the whole story? What does the child have?
Post fall concussion, because if bleeding would have happened, she would have been sicker.
Bleeding would have happened means bleeding where?
Intracranial bleed, post fall. After fall, she has weakness.
Correct. So she fell and she immediately had a weakness. As soon as she fall.
So she fell, and they immediately rushed her to the hospital. There, when they were evaluating her and trying to console the child, is when they noticed the weakness.
Correct. So you're saying there's no intracranial bleeding. So for the fall. So now that I agree, there's no intracranial bleeding. But I'm asking you a different question. Suppose somebody has a fall and has an intracranial bleeding. When will they develop a neurodeficit? Sometime later, no? At least it can't be instant, right? So that's anyway not related. So what else now? So what is the event that has happened to this baby? She has one-sided weakness. So she has acute infantile hemiplegia. Yes or no? So she has acute infantile hemiplegia. It's a sudden event. So it is a vascular event. So this baby has had a stroke. Now what you have to decide is the fall related in any way or unrelated? That is one thing. And then you have to try and figure out what could be the cause of the stroke. Right? So is the fall related or unrelated? So in the previous case, there was one discussion that fall of the previous child could have been a seizure. So do you think this fall could have been a seizure?
No, so I think the fall was coincidental and not a seizure. There was, after the fall, the child was active immediately. There was no history of any post-ictal drowsiness after the fall. And post-fall drowsiness.
Means this entity that a child falls, and you if you give a deep thought, sometimes you might figure out that the child fell due to a seizure. That has to be in a specific situation where you didn't expect the child to fall and suddenly the child fell. Means if the child fell without tripping, without slipping on the ground, nothing, means you didn't expect and suddenly the child fell, then you think it is a seizure. So here it was fall from the bed, so this was definitely not a seizure. But still, is the fall related? So it has been found that sometimes these falls can trigger off a vascular event. That has been found and it has been noted, right? Now, what is the cause of that acute infantile hemiplegia?
The fall is significant, 1 meter, from a height of 1 meter, that is almost 3 feet. So the fall must have been, it's not just falling from a bed, is usually 18 inches. And he fell on the head.
Which again you have to confirm. So who sleeps at a height of 1 meter? So you have to confirm whether the bed was really 1 meter, or then they have a malia and on that malia the baby was put, and all those things you have to confirm, right? Okay, fine. So possible pathology we said is a vascular event, etiology. Hmm?
Mineralizing angiopathy of childhood can be triggered by trivial trauma. Can be stroke leading to weakness followed by fall.
Stroke or weakness leading to a fall is very much right, but then the history would have been that the child was standing, playing with something, and suddenly fell. So that is when there was a weakness which made the child fall, right? So here the child was sleeping. So one is angiopathy. What else can it be? Could be sickle cell disease.
Thrombotic phenomena, like more related towards like thrombosis.
Due to
Child
what?
have-
Prothrombotic etiology, sir. Like if
Yeah, so theoretically all that is possible. So you would say that theoretically you'll have to go through all the causes of acute infantile hemiplegia, but clinically nothing seems to be visible, right?
We have discussed this earlier many times, that any vascular event is thrombosis, embolism, hemorrhage, vasculitis, or a transient vascular obstruction. Transient vascular obstruction could be a vasculospasm, as sometimes a metabolic disorders could do that, MELAs could do that, mitochondrial, or a transient block like common causes iron deficiency anemia at this age. Just a past infancy, a common iron deficiency. So today we call it an arteriopathy, which means nothing. We do not know what's the pathology in that arterial. So we call it an arteriopathy. And all that we expect is nothing neurological except improving hemiparesis. If that is so, then we are reasonably fine. The question is, why should iron deficiency cause that?
In iron deficiency anemia, the RBCs are not pliable. They are stuck to each other and cause vascular obstruction, sir. Membrane
There are
and thrombocytosis.
there are lot many RBCs hemolyzing in hemolytic anemia. So, who is responsible for a possible stroke in an iron deficiency?
Thrombocytosis.
It's the platelets. Okay, and therefore it is association. You know, pica and iron deficiency. You know, iron deficiency and poor school performance. So multiple reasons.
Of this one AC.
नाम क्या है उसका? इकरा, इकरा, आप मत कहो, उसको देखने दो। इकरा ऐसे पुकारने पर देख रही है? नहीं, ऐसा वो लकवा जैसा होने के बाद भी सुन रही है, देख रही है? आप सीधे बैठो और राइट हैंड आगे आने दो। हाँ,
Child looks well built and well nourished, who is alert and awake. With there is positive movement in
non-dysmorphic.
dysmorphism. Head circumference appears normal for age and height. Child is there is weakness of right upper limb and not moving the right upper limb and also right lower limb.
आप ये हाथ पकड़ के रखो।
Nasolabial folds bilaterally
ये हाथ
intact,
पकड़
but
के रखो। ये हाथ पकड़ने की जरूरत
able to close both the eyes. Wrinkling of forehead is intact.
पकड़ के चलती है क्या, बताओ हमको।
Winter. नहीं चलो जाएंगे कर जाएंगे चलो घर पे।
Let him go. Let him go.
दूध कौन सा है? सिर्फ दूध सिर्फ आपका है कि बाहर का है? बराबर है। दूध कम है, बाहर का खाना ज्यादा है। आपका भी दूध है, आपका नहीं है तो बाहर का ही है। बॉटल से पीती है। पहले से ही थोड़ा चाहिए कि अभी अभी थोड़ा लेती है? और
You expect a spasticity, no? Basically, towards the spasticity, then let him go. Make it materially. So child does not. This was on an affected side. On an affected side, towards the spasticity. Yeah, come on, this side. Show me the tone. Tone.
What do you do? What do you
and also the extensor.
It is best seen in at the hip by sudden abduction.
I think demonstration of spasticity is very difficult unless you practice it well. And you know that is velocity dependent. You need to do it fast. And if you don't do it fast, then you won't get it. And if it's a mild spasticity, you would easily miss it. So that is important. And I think many times most of our patients are nutritionally little low, so they tend to be hypotonic. And in that, you have to fish out a spasticity. It's not easy, so must practice. Almost many children here are hypotonic, malnourished. So learn to pick up spasticity in that apparently nutritionally hypotonic child. Otherwise, that's where you are caught up in an examination, right?
Dorsiflexors of ankle, extension of the knee, and abduction are three movements which you will try to pick up spasticity. Anti-gravity, no?
Impression: a 14-month-old girl brought with complaints of sudden onset right-sided hemiparesis with right-sided upper motor neuron facial palsy with reduced speech output without altered sensorium, seizures, who's completely immunized, developmentally normal, is most likely a case of arterial ischemic stroke in the left MCA territory, lesion being in the internal capsule, possibly thromboembolic to rule out an underlying prothrombotic state. On arrival, she was afebrile, vitally stable with a heart rate of 120 per minute, which is regular in rhythm, respiratory rate of 32 per minute, maintaining a saturation of 99% on room air, peripheral pulses are well felt and extremities are warm. The blood pressure was maintained at the 50th centile. On head-to-toe examination, the findings that were apparent included a deviation of angle of mouth to the left, drooling of saliva on the right side, and loss of the nasolabial folds on the right side. She also had wrist widening and pallor on head-to-toe examination. Systemic examination: the child was alert and conscious. Um, she was oriented to, the child was alert and conscious. Speech, she had decreased verbal output. Gait, we could not assess, but the child could not bear weight on the right side. Cranial nerve examination showed a right upper motor neuron facial palsy. On motor examination, the tone was decreased in the right upper and lower limbs. This was examined 24 hours after the onset of the weakness. Power was 2 by 5. Power was initially 0 by 5 in the upper and the right, upper and lower right limbs. After currently, the power is around 2 by 5 in the right upper and lower limbs across all joints. Impression: 1 year, 2 month old girl with complaints of right sided hemiparesis with right sided upper motor neuron facial palsy, without other cranial nerve involvements, without any sensory deficits or signs of raised ICP, with reduced speech output, is most likely an arterial ischemic stroke, thromboembolic lesion localized to the internal capsule, left MCA territory.
Theology.
Etiology being an underlying, we could rule out an underlying prothrombotic state in the child, underlying prothrombotic state of vasculitis or mineralizing angiopathy of the lenticular striatum. We did proceeded with neuroimaging for the child. MRI brain was done, which show MRI brain with MRA was done, which showed an acute non-hemorrhagic infarct in the left caudate nucleus and lentiform nucleus. On the complete blood count, the child had a hemoglobin of 8.6. She had a hematocrit of 24. She had microcytic hypochromic anemia with total counts of 7,000 on arrival and platelets of 5 lakh. As part of her investigation workup, we plan to send the prothrombotic workup after 3 months. We've done a 2D COPE for her, which is normal. We've done a major vessel screening for her, which is also normal. And we start, that is the workup that we sent for her.
And so how will you treat her?
So for her, after ruling out a hemorrhage on neuroimaging, we started the child on aspirin after ruling out a hemorrhage, and we started her on occupational therapy and physiotherapy, and we've we'll be treating the anemia for her, underlying anemia, and occupational and physiotherapy will be the mainstay of treatment for her now. And the parents have been counseled about the possible gain in function over the course with occupational and physiotherapy.
So you've not started treating with iron.
Not yet. Actually, she's running a fever, and she's also developed raised counts during her admission. So currently, we've not started her on hematinics yet. Only microcity. She had an MCV of 60.
RDW.
RDW was 16. 16. Peripheral smear has shown hypochromic cells and microcytic cells. And we've also sent
No megaloblasts.
no megaloblasts. And we'd also sent a sickling for her, which is awaited.
Surprising, but no pigmentation.
No pigmentation.
Also, it was interesting to note that while we thought that could be an internal capsule-like lesion, the MRI shows that it is thalamic and caudate nucleus infarct. While we thought that with thalamic and caudate we will see more of extrapyramidal signs, but here we thought it should be a internal capsule, but it's not like that. And I don't know whether some other signs will develop as the child grows. Do you think it's related to iron deficiency?
She has thrombocytosis with platelets of 5 lakhs, but
I think it is related. What do you think, sir?
Yeah, maybe we don't know, but best to treat it. Anyway, we are going to treat the iron deficiency. So we should treat that. Yeah. And you all often forget, but you should also give dietary advice that why this iron deficiency should not recur in the future. So that also is part of the treatment, right? Fine. I think we'll stop here. Yeah. Any inputs from the online audience? Any questions?
No, Rajesh, thank you very much. Thank you, Amdekar sir, and everyone, all faculty and students as well.
Thank you. Thank you. Now, from next Thursday, before everyone leaves, there is a change in the timing of the class. So instead of 6 to 8, it will be 5 to 7. So
Noted,
please,
Rajesh.
please spread the message wherever you have been, every one of you who have been in contact with anybody, please spread the message that the timing will change to 5 to 7. Okay? Thank you.
Okay, Rajesh. Thank you.